Thanks so much, Lee. I must say it's a thrill to help to kick off this tremendous conference and this tremendous day. And I do especially want to pay tribute to the many patients and family members and caregivers who are here in the room. It really is true. I mean it when I say that your presence here changes the way we talk about and think about quality in Ontario's healthcare system. And I do want to tip my hat to Health Quality Ontario, which I think is really pushing the boundaries and doing very exciting work in partnership with patients to force us all to do better in our work. The experience of citizens who are somewhat arbitrarily labeled patients when they happen to set foot in our offices or institutions is, of course, the best place to start as we grapple with the tough questions about healthcare quality. And when asked in a 2013 Commonwealth Fund survey, 74% of Ontarians gave high ratings to the care they received. I think we have all seen and experienced excellence in our healthcare system. And in fact, much of that excellence is going to be showcased here at Health Quality Transformation. But our challenges remain substantial. And I have to say, what's sometimes disheartening for me, both as a clinician and as an administrator, is how familiar those challenges seem. These challenges adversely affect patient experience profoundly, but they also impair population health and drive up costs in our healthcare system unnecessarily. As a family doctor, I see them every day. Difficulty accessing timely primary care, long waits for specialty care, critical safety events in our hospitals and institutions, poor access to medically necessary prescription medicines, and variations in care that can frankly sound frightening. These problems haven't changed much in the last decade, but the need to solve them has become more pressing. Today, as you've heard, HQO is releasing an important report called Measuring Up, which takes stock of where we are at in Ontario with some of those system problems. That report rightly points out that we have essentially flatlined in many areas, failing to make progress, particularly in the areas of timely access to primary care, the unaffordable cost of prescription drugs, and follow-up for sick patients after they leave the hospital. As the patients, family members, and caregivers in this room know, these problems are not just statistics on a page. For you and for me, each of them has a face. The 72-year-old woman in my practice who waited for 22 hours in the emergency department in excruciating pain, only to be sent home with a referral to see a specialist 3 months from now. The young man who can't afford his asthma medicine and spaces out his puffers, afraid to exercise in case he brings on an asthma attack that he can't afford to treat. The woman who's always wondered whether the hysterectomy she had in her 30s was actually necessary. And yet, if you look at the program for this conference, if you listen to the stories of the teams who will be honored with the Minister's Medal, which, to be honest, the stories always kind of leave me misty-eyed because they're so inspiring. If you eavesdrop on the conversations in the hallway today, you may be struck, as I have repeatedly been, that actually we have what we need to solve our challenges. We have the data and the capacity to collect more. We have the commitment of providers, institutions, and citizens to do better. We have the models that have been shown to work. So the good news is, and I want to start with the good news this morning, that the answers to our challenges are not magical. They're not unknown or beyond our reach. Many of them have actually already been implemented here in Ontario, but, and here's the nub of our problem, on a small scale. We have lots of examples of success to point to for some body parts, in some places, some of the time. The work of HQO has been in part to push us to implement those local solutions, and you don't need to look any further than the over 1,000, I think it is now, quality improvement plans that hospitals, long-term care facilities, CCACs, and primary care organizations submit to HQO every year for inspiring examples of that local work. The long-term care home in Waterloo, Wellington that put in place care maps to understand why residents fall and prevent those falls from happening. The Northwest CCAC's expansion of telehome care to try to reduce hospital readmissions. The many family health teams doing coordinated care planning for their most vulnerable patients, including my own family health team at Women's College. These are terrific examples, they're heartening. But my challenge to the assembled group today is this. The name of our conference is not Health Quality Example. It's Health Quality Transformation. What good are terrific programs to the patients and citizens who don't happen to luck into them? My colleague Stephen Lewis from Saskatchewan observed back in 2007 that, and I quote, "The single biggest problem in Canadian healthcare is the failure to apply ingenuity on a grand scale." So that's the bad news. Here in Ontario and across Canada, we fall down when it comes to moving from the pilot project to the system solution. And the unfortunate result of this is, for the patients in the room, the kind of care you get often depends not on whether someone has figured out the best possible way to deliver it, but on whether that someone happens to live in your community or your neighborhood. That's how we've ended up with the situation where the likelihood that you'll be able to see your primary care provider on the same day or next day when you're sick is 29% if you live in Muskoka and 57% if you live in Caledon. So this morning, amidst the very well-deserved celebration of all we're achieving in Ontario's healthcare system, I want to turn our attention to the question of how we can scale up our successes so that their benefits can be enjoyed by everyone. Let's begin by characterizing the problem that I hope we can tackle together. Within Ontario, we see enormous variations in care. This is just one example that's led to a great deal of attention. It's the use of antipsychotic medications for residents of Ontario's long-term care facilities. For some residents, these medicines may play an important role in managing the behavioral symptoms of dementia, such as agitation and aggression. But their use is very controversial because of side effects such as sedation, the higher risk of falls, and a slightly increased risk of death. Family members of long-term care residents may see their loved ones struggling to communicate or sleeping for large parts of the day as a result of antipsychotic medication use, something I've certainly seen firsthand. As this graph illustrates, in some long-term care homes in Ontario today, the number of residents over the age of 65 being prescribed antipsychotic medications is 0. In others, up to 2/3 of the residents are being prescribed those drugs. Now, some of that variation is certainly due to differences in patient populations, but I can assure you, not all of it. Treatment for cardiac conditions has also been shown to vary widely across the province, as has been illustrated by the work of Jack Tu, among many others. As you can see from this map, in the Toronto Central region, patients are 20% less likely than the Ontario average to receive cardiac catheterization, an invasive intervention for heart disease, compared to people living in the southeast region of the province, where patients receive this procedure 20 times more often than the average. And that's not even to say what the right percentage is, but just to illustrate the enormous variation in rates of interventions. Of course, variations in care might be understandable in cases where we don't know what the best practice is, or where particular populations have different preferences or values about the care they want to receive. But let's be honest, too often that's not the case. We know what best practice looks like for a wide range of cancers, heart disease, stroke, diabetes, and a host of other health issues. Yet, we apply that knowledge inconsistently. It's for this reason that variations in care are a major focus of the work of organizations like HQO, as well as many of the organizations represented in this room today. This problem of variations in care has been exacerbated by what some have called pilot project-itis, an affliction of the Canadian healthcare system. So innovation in our world, in the healthcare world, often begins with some kind of report or flag that there's a problem that needs to be addressed. Some of you might have been inspired in your own work by an HQO report, like the one on antipsychotic medicines, or when you realized that the rates of colorectal screening in your family practice or family health team were below the provincial average, or when patients raised an issue or a concern about the care that they were receiving in your organization. And so you and your team might have said, well, this is a problem, and we'd like to do something about it. You started to implement change. Maybe you put a new safety checklist in place in the operating room, or an approach to improving the way that patients access home care when they leave the hospital. Maybe you worked to ensure that patients who needed to see their primary care provider on a certain day could actually see their primary care provider on that day. And of course, because you all know how to do this well, you would have measured your results to see how effective the change you were making actually was. Look, this is a very reasonable approach to change. You respond to a problem, you test out an approach to addressing it, you measure the results. In fact, it's the basis for dozens, probably even hundreds, of quality improvement initiatives across Ontario. But what about everyone else? Canada has been called a nation of pilot projects because we have difficulty moving from the trial change to the permanent state, from the local example to the system-wide difference. Some of the difficulty in making system-level change is because when the people who sign up to participate in early projects or research or optional programs are what we call the early adopters, teams eager to be at the leading edge who get a charge out of doing something different or new. But as we've seen from the data on care variation, change does not spread organically. So, what does help change behavior? At conferences like this one, we often talk about the power of data. And it's true that you can't manage what you don't measure. And actually, while we have a lot of data in Canadian healthcare, we don't do as good a job as many other countries of putting those data into the hands of providers and patients who can then do something with it. It has been shown to be the case that when you put those data in the hands of providers and patients, when you show people how their practice patterns compare to others and how their practice patterns compare to best practice, something does start to shift inside of them. But one of the ways we fall down, one of the critical reasons we fall down when it comes to reducing care variation and implementing best practices is that we assume that when you give people that data, they're going to know what to do with it. Successful behavior change depends on a lot more than just knowing what the right thing to do is. Look, people, including healthcare workers, including patients, are creatures of habit. If I learned as part of my medical training to do a urine test on every patient who comes to my office for a so-called annual checkup, it's going to feel weird and somehow less than attentive for me to stop doing that. I might know that there's no evidence to do it. In fact, I might know that it's a waste of money and that it could harm my patients by picking up meaningless abnormalities that I will then feel compelled to investigate. And yet my hand itches to tick the box on the form. It's also, frankly, hard for my patients who might be used to having their urine checked either by me or by whoever used to be their family doctor, and they don't feel somehow as well cared for when I tell them that we shouldn't be doing that test anymore. Or that furthermore, there's no evidence that the annual checkup itself does anything for their health, and we should probably stop doing that as well. My point is that providing data alone or yelling louder at healthcare workers or organizations or patients to do better based on those data isn't enough. What we've learned from decades of research in human psychology, behavioral economics, and change management is that if you want people to change their behavior, you need to make the right thing to do the easy thing to do, which means structural system change, not just local pilots. Data are necessary, but they're not sufficient. We have to provide people with the tools they need to do their work differently than the way they did it yesterday. This is the reason why less than 40% of healthcare improvement projects successfully expand beyond the early group of adopters who first bring them to life. This process of successful innovation beyond the local pilot is what's sometimes referred to as spread and scale. Spread is about learning from each other and sharing best practices. It's been referred to as horizontal diffusion, either within an organization or across a healthcare system. It's where a new approach that has been shown to work catches on as location after location sees how well it's working nearby. That's spread. Scale, on the other hand, is about looking for opportunities to implement a single solution, often with a single stroke of the pen, across the entire system. And what's critical to recognize, something that I think we don't think about very much in the world of quality improvement, is that depending on the innovation, spread may be more appropriate than scale, scale tools may be more appropriate than spread, or there may be a need for the combination of the two in order to disseminate success. So let me talk first a little bit about spread, because I know it sounds like it should just be one of those things that catches on organically, but it doesn't simply happen because an innovation has been shown to be successful. Why is that? Often, it's because nobody in the system holds the responsibility to make it happen. It's that simple. If I can get my hospital to reduce the number of people who have a bad outcome in surgery, why would I worry about the outcomes of the hospital down the street? What's the incentive for my organization to convince another organization to adopt the same approach to surgery that we've implemented? Now, some of you may be thinking, well, obviously it's the job of the Ministry of Health, or obviously it's the job of the local health integration networks that help to plan our care across our geographic regions. But actually, the ministry and the LHIN frequently have no levers to implement that kind of change. Remember, most doctors remain independent practitioners. Most hospitals remain quasi-independently functioning from government. So the process of spread depends on the willingness of those people and institutions to engage in change. And frankly, that can sometimes be a pretty tall order. One example of spread initiatives that's going to be featured here at this conference is Ontario's ARCTIC program, the Adopting Research to Improve Care program. The goal of ARCTIC is to speed up the process of spread for successful local initiatives. So just as an example, last year ARCTIC funded the spread of an initiative aimed at ensuring that patients who have comorbid or both major depressive disorder and alcohol dependence would get access to treatment for both conditions simultaneously. It's a tremendous initiative. If you look at the intensive work involved in getting organizations to implement just that one project across the entire province, you start to understand how difficult spread is to be intentional about. Now, scale, on the other hand, is about reach. This happens when a new approach is adopted across an entire system, usually across an entire geographic area at once, like a health region or a province. Scale requires centralized power, it requires political will, and it requires stakeholder buy-in in order to accomplish large-scale change. And we've seen successful examples of change in Ontario, of scale in Ontario also. For example, the quality improvement plans, which I mentioned earlier, where 5 years ago, every hospital was required to create an approach to improving quality based on a common set of provincial quality indicators. This was then further scaled out to include long-term care, community care, and primary care. Another terrific example of scale is Canadian Blood Services, which is a truly pan-Canadian healthcare delivery organization that's responsible for the entirety of the blood supply across provincial jurisdiction barriers for every part of Canada outside Quebec. But let's be honest, scale requires significant resources, and it requires the expenditure of political capital. If we wait for scale to make all the changes that we need, we're going to be waiting for a long time. So, how do we know when to use the tools of spread and when to use the tools of scale? Making change is always about the art of the possible. Determining which set of tools you're going to use requires us to be honest with ourselves about what tools we actually have available to us. Sometimes it would be great to just pass a piece of legislation requiring hospitals or providers to do something, but it isn't actually feasible. Other times it would be great to engage providers and patients and inspire them to drive change locally, but they're frankly unwilling or unable to do so. So I'm recognizing that this is maybe starting to sound a little bit theoretical to all of you. I'm going to spend a little bit of time now on a couple of examples that require us to put our energies into both spread and scale efforts to illustrate what I'm talking about. And I want to focus on the problem that underpins a lot of the variations in care that we've been discussing this morning. The fact that on the one hand, some Ontarians are getting too much health care, in fact, so much that it's harming them, while other Ontarians are not getting enough, the so-called problems of underutilization and overutilization. So the first project, addressing overutilization, started with a recognition that harmful, wasteful, and inappropriate tests, treatments, and procedures are a major threat to health. Some of you may recognize Choosing Wisely Canada. It's a national campaign led by Dr. Wendy Levinson here at the University of Toronto. Its evaluation is being housed at my own Women's College Hospital. To illustrate the need for this campaign, I want to tell you about a patient we're going to call Sam, who came under the care of a cardiologist colleague of mine. Sam was a perfectly healthy man in his 60s. He didn't smoke, he didn't drink. In fact, he was a world-ranked athlete in a competitive sport. And as part of his compensation at a fancy Bay Street firm in downtown Toronto, Sam went every year for an executive physical at a private clinic. One year, in spite of the fact that he felt perfectly well, Sam was subjected to an exercise stress test, just in case. Some potential incidental abnormalities were identified, and Sam ended up with an angiogram. Happily, the angiogram confirmed that Sam did not have coronary artery disease, but not before he suffered a stroke on the table, a known complication of the procedure that occurs in about 1 in every 1,000 cases. This healthy athlete will never play his sport again because he's paralyzed on one side of his body as a direct result of a completely unnecessary and inappropriate test. Now, when I tell Sam's stories to friends and family members outside the medical profession, in fact, my own partner, I watch them struggle with the question, but what if they'd found something? And wonder if the risks still aren't worth it to pick up that one cancer or that one undiagnosed heart condition. But that's exactly the point. We need to stop thinking only about the benefits and start having an honest conversation about harm. Millions of Canadians are harmed every year by inappropriate, wasteful, and harmful tests and prescriptions. So as part of the Choosing Wisely campaign, our national specialty associations have acted to create lists of what we call things that patients and physicians should question. Mammography for young women, PSA testing for men not at risk, drugs that are harmful to elderly patients. We need, as a community, to acknowledge that even good tests and drugs, when used on the wrong people or at the wrong interval, really harm people. And we need to start to wrestle with a culture change that doesn't just lay the responsibility on a patient who read something on the internet or the doctor who reached too quickly for the prescription pad, but that looks for ways in which we can support each other in choosing more wisely than we currently do. Now, the Choosing Wisely campaign has inspired dozens and dozens of research studies and pilot projects, yes, you heard me correctly, aimed at reducing inappropriate tests and interventions across the country. And of course, some of these are proving to be very effective, and some of them are proving to be not very effective at all. The trick now is for the successful ones to get them past the pilot stage. We need to employ our tools of spread so that if my hospital reduces inappropriate lab tests before surgery, yours doesn't have to reinvent the wheel. So that if your association has put together patient engagement modules on how to push back against unnecessary care, everyone else's association starts using those modules too. But when it comes to reducing overutilization, we also need to use our tools of scale. This may include, among other things, delisting certain tests or interventions from our public programs based on evidence, as we did in Ontario with serum vitamin D testing. In my view, we should not be afraid to use evidence to drive decisions about what we pay for in our public programs. After all, the purpose of our greatly cherished public health care system is to improve the health of the population. And if we are paying for things that don't do that, we ought rightly reconsider. Of course, just as we struggle with overuse and inappropriate use, which drives in part variations in care, we also struggle with underuse in Ontario. I don't want to leave you with the impression that less care is always better. Where there is good evidence that care improves outcomes, everyone should have equal access or equitable access to it. As we continue to find, just as an example, who is at greatest risk for colon, breast, and cervical cancers, we still have work to do to make sure that those who should be getting screened regularly are in fact doing so. And actually, the HQO report Measuring Up that's being released today talks, just as an example, about diabetes screening exams for eye disease related to diabetes and the enormous variations in inequities in access to those kinds of screening tests. Many of you have been involved in projects to reach out to underscreened or even never screened populations, just like this Cancer Care Ontario mobile van does. When I worked in the north, we used to wait for the eye van to come up to do the ocular screening for diabetics, and in many of our marginalized communities, even in the inner city of downtown Toronto, we're doing cervical screening out of mobile units like this one. Again, the problem of underutilization, though, requires that successful projects like that actually be spread and scaled across the province. But this brings us to one of the biggest barriers we encounter when it comes to spreading and scaling change in healthcare, the fact that it isn't anyone's job. One of the 7 deadly spread sins that the Institute for Healthcare Improvement in the U.S. identifies for spreading solutions is relying on the person or team who drove the pilot to also be responsible for system-wide spread. I think that's sin number 5. You can see the other 6 on the slide above me. In Ontario, we've actually been guilty of every single one of those 7, plus a couple others that aren't included on the list. So, if the group that implemented the pilot can't do the job of implementing the broader system change, who can help? Well, it isn't just because we're at Health Quality Ontario's annual showcase event that I'm driven to name HQO here. Because it works directly with patients, healthcare leaders, clinicians, scholars, and government, HQO has at least some of the tools that we need to help us get over our parochial approaches to quality improvement. And in fact, HQO's new strat plan speaks specifically about the notion of supporting broad uptake of quality innovations that provide good value for money. I can think of no better theme for the work of this important organization, and I would put in a plug, in fact, perhaps even no better theme for next year's conference. But to leave it to HQO alone is to duck our own responsibilities. How many of us in this room have been involved in successful local projects without giving a second thought to our obligations beyond our walls? If you are a health provider or a patient, it's time to view the quality initiative that you're involved in as the beginning of a system-wide journey rather than just a local success story and patting yourself on the back. If you're a researcher, it's time to start evaluating levers of spread and scale to find those that really drive change beyond the press release or the publication. If you're a politician or a system leader, I implore you to reconsider the approach to change that has relied on looking for coalitions of the willing and shovel-ready projects that advance care in some communities while leaving the rest behind. The responsibility for identifying successful models and then committing to them system-wide, of course, lies with all of us. Sooner rather than later, we're going to have to get some clarity about when to apply the tools of spread, when to apply the tools of scale, and how to do both well. I began this morning by saying that when a citizen happens to set foot in our offices or institutions, he or she is suddenly labeled a patient. Of course, we're all citizens. Before any of us is a patient, a caregiver, a healthcare provider, or a system leader. I actually think that it is as citizens that we need to address and engage with this dilemma of pilot projects in Canadian healthcare. Because of course, as patients or providers, we might be content with giving or receiving the best possible care in our local organizations. But as citizens, it must be totally unacceptable to us that our neighbors would get anything less than what we would want for ourselves and our loved ones. This, then, is the challenge for HQO and for each of us. We can celebrate our successes, and of course we should, but we need to start to shift the balance away from what it takes to do better locally and towards a deeper understanding of what it takes to pivot from the pilot to the system solution, from health quality example to health quality transformation. Thank you.